My name is Joachim Fandrey. I'm from Essen University and I'm running the Department of Physiology. This is the topic, and you have actually heard why it may be useful and desirable to prevent transfusion. I don't have to go over all the different points. However, I put up this slide for another issue, and that is shown on the next slide. The recurrent use of red-packed cells gives this rise and fall in hemoglobin concentration as opposed to the continuous stimulation of erythropoiesis. And what my group and my department is mostly interested in is in hypoxia and tumor hypoxia in particular and erythropoiesis. And if you see this kind of picture, it immediately comes up your mind that this transfusion may cause cyclic intermittent hypoxia. Now, this is something that is for the basic scientists of considerable interest, since the oxygen tension in the tumor and these cycling, intermittent, fluctuating, transient, whatever hypoxia you call this, will change the tumor cells in two different settings, being one, the tumor progression and the tumor expansion. And between these two different states of oxygenation, you may have genetic adaptation and genetic alteration. What we know now is that genetic instability, in particular, as angiogenesis and also the differentiation state critically depends on the oxygen tension. So if you change between these different states of oxygenation, it may well have unwanted effects, and some of the data we've just seen in the presentations actually I think worth to be studied in further detail with respect to these changes in oxygenation due to transfusion. Now, the question of EPO receptors in tumors is now going on for some years, and I believe one of the reasons why basic scientists should speak about this issue is that some of the stories have to be carefully evaluated, and in particular with respect to potential implications for the clinical setting. So the open questions are the EPO receptors on tumor cells, are they functional, and actually do have ESAs any effect on tumor cells via EPO receptor signaling? I've put this very simple slide up, and I think the simplicity of the slide makes it very useful because you can use it for all the different issues that we have in this particular setting on EPO receptors and the potential effects on tumor cells. There's the question of local concentration of EPO. Does the concentration that is achieved therapeutically in any way correlate with the in vitro studies that have been performed with tumor cells? The signaling of the receptor has been worked out for erythropoietin cells, but the signaling pathways, but this is the usual STAT5 signaling in erythropoietin cells, but there may be other signaling pathways in tumor cells. The question is whether this is specific to erythropoietin receptor binding. Now, Mario just alluded to this little question mark here because most of the receptor, probably 90% or more of the EPO receptor is actually found intracellularly, while it's processed and then has to be transported to the membrane to form this dimer and then bind EPO. And as you've seen, this was worth a science paper this year. This story is not resolved, and the dynamics of receptor traveling from the intracellular space to the membrane and back, and the recycling of the receptor is something that has also to be considered in tumor cells. Two slides from the Elliott paper that came out 4 years ago that was very critical with the EPO receptor antibodies. And I believe it's worth discussing this issue because one of the antibodies, C20, that is sold, that's available commercially by Santa Cruz, was used in many studies. The problem with this antibody is that it's not specific to the EPO receptor. The positive control is this big dot here, and then there is UT7. This is one cell line that is responsive, an erythroleukemic cell line that's responsive to erythropoietin, and this gives a weak signal here at the correct size where the EPO receptor should be expected. And the other were these tumor cells that were used in several other studies. So first evidence was that this antibody detects bands that do not correspond to the positive control in these transfected cells or in the erythroleukemic cells. And second, if you then pre-treat or block the cell lysates with heat shock protein peptide that has some similarity to the original antigen that was used for immunization, you see that this band that was previously claimed to be EPO receptor is disimproving. So it's displaced, which indicates, and there is additional data in this paper, that this antibody detects this heat shock protein and is not specific for EPO receptor. Nevertheless, why I'm telling this is that Henke used some of the patients and some of the tissues he had from this original study and used this antibody, the C20 antiserum, to classify his patients into the two groups, the EPO receptor positive and the negative, and then had this worse outcome in the EPO receptor positive patients. This story does not indicate that it's EPO receptor dependent, since the antibody is not specific. So if you use a reagent that recognizes this HSP70 protein, you can't just say it's EPO receptor positive cells that are responsible for the worse outcome. We know that HSP70 is, for example, hypoxia-inducible and is found in rapidly growing tumors, so it may just be selection for tumors that grow more rapidly or are just more malignant. Nevertheless, in the recent recommendation, in the unabridged version that came up in Blood 2-3 weeks ago from the recommendation by Ash, this story was still alluded to and it's referenced to, although they say that the antibody may not be specific, but I think this is just confusing if you have not non-valuable reagents for your studies. Now, a few other issues that come across your mind when you look at the preclinical studies that there were very high concentrations used, and particularly some of the in vitro experiments were done with synchronized cells, which you will not see in a tumor with all his divergent facets. And some of the positive or negative score were not consistent, so there are differences between the studies. One study uses a cell line as a positive control, which is then considered negative in another one. And the intracellular signaling is still not fully resolved. And I would like to show you this one, because these are two papers, one from the Sitkovsky group and one from Terry Lappin's group, who's also in the audience. And they showed that there may be signaling, which means they found phosphorylation of the intracellular proteins that are linked to EPO receptor signaling. However, if you then look in these ovarian cancer cells, there is, depending on higher or even with higher concentrations of EPO, there is no growth. And so there may be some phosphorylation, but you don't see the growth response you would expect. And then in this other paper, fortunately, they have the positive control. So this is something you have to include. So in this case, the positive control, this erythroleukemic cell line that responded to EPO, these are much more reasonable concentrations for EPO, but again, this small lung cell, tumor cell, did not respond, despite there was some evidence for activation of signaling molecules. The EPO receptor gene itself, it's not an oncogene, so if you overexpress it, it does not give a growth advantage. And many of the studies detect EPO receptor mRNA, which does not necessarily mean that there's also the protein on the outside of the cell, and I have already alluded to this very recent study that addresses this issue. The binding of EPO may be very weak or non-detectable, and again, if you perform these studies, you have to use the native EPO-responsive cells, progenitor cells, erythroprogenitor cells, or, for example, this UT7 cell line, to have a positive control and be sure how to interpret your binding data. Now, having this problem with the antibody that is not specific and the different cell lines, early this year, actually the online data were available in February, but this came out in May, was a study by Swift. And I apologize for this slide, but it's just to show you that this is a group from Amgen. They used 209 tumor cell lines, and you just see the different groups of tumors. And the only thing that lights up here for EPO receptor mRNA is the UT7, the positive control, and this is the detection of the protein with a newly developed antibody, the A82, that was developed by Amgen out of a pool of antibodies. So what they did, they used all the different tumor cell lines. They made a new antibody, and they found protein levels, significant protein levels, only in the progenitor cells, the UT7, the erythroleukemic cells, and another one that is, those are the progenitor cells. So all the other tumor cell lines did not show significant protein expressed in the cells. And in fact, if you look at these, there is one non-small lung cancer cell line here, the 661, that then showed some binding of radioactive EPO, very little, but no signaling. So you have to do the full panel, you have to look for the protein, for the signaling pathway, and then for the response of the cells to be really sure that there is some signaling. And so far, these 209 tumor cell lines, many of which were used in other in vitro studies, do not show signaling and do not show growth response. The issue of angiogenesis induced by EPO is also very difficult because the studies so far have some funny parts in it. So some studies use mammary carcinoma cell lines that overexpress the EPO receptor and then set up an animal experiment to look for angiogenesis. Or they used inactive antagonists where the side effect, if you consider this as a therapeutic, would be severe anemia induction by antagonizing the physiological response of EPO as well. And then is there the issue of the injection of erythropoeitin and the concentration within the tumor. And I've put this very simple slide because one of the major issues in the tumor microenvironment is the poor perfusion. This is the issue in radiation therapy where the oxygen tension is so low due to low perfusion, and this is the issue, how to bring chemotherapeutics to your tumor cells. So in this particular study by Hardy, there was an injection of 280,000 milliunits, so 280 units of EPO into the tumor. However, there was no systemic response with respect to erythropoiesis, indicating that this EPO at this extremely high concentration does not come out of the tumor. Now, if you turn the whole thing around, the question is how does the EPO from the bloodstream come into the tumor to reach sufficiently high concentrations that were claimed to be required for the effects here. So I think this is that is still very open, and some of the models we are also using as basic scientists need to be improved. Mary has already alluded to this work on the macrophages, which is really interesting, and there is some collaborative work going on to look for the effects and dissect the signaling pathways. Now, one other study that came back to back with the blood paper I was alluding to was another paper. Sinclair is also a group from Amgen that addressed this question of functional EPO receptors on endothelial cells with respect to angiogenesis. You see the positive control here that was included. And the other thing they did in this study, and this may only be done by a company as a vehicle for these studies, they used the formulation buffer of EPO. And as we've published recently, is that there may be ingredients in the buffer. If you use extreme high concentrations in your in vitro setting, you may see effects that are non-specific to the erythropoietin or the ESA. Now, if you then look for and this is a blow-up, so this is the binding of erythropoietin, so this is a positive control, and there is very, very little. I mean, these are different dimensions. And if you then look for the angiogenic response in rat cornea assay, and you count the vessel numbers, and again, VEGF, the known vascular endothelial growth factor, the positive control has a robust response, and the EPO does have no response, and the vascular area is also not increased. So if you do all the controls and then use the respective vehicle, there is no effect observed in this study. So this is summing up in the cancer cell, the question about the receptor. Recent work from Harvey Loder's lab, who is one of the major player in deciphering the erythropoietin receptor signaling in erythroid cells, indicated that it's the homodimer that we know from erythroprogenitor cells and not these potential beta-common subunit that was found in neuronal cells and that was alluded to be involved in signaling. So the signaling within tumor cells is not clear. There is equivocal evidence from different cells, as I said, whether there is signaling or not. And I have already alluded to the tumor microenvironment, where we have to carefully consider what are the EPO concentrations we may expect within the tumor that actually reach the tumor to exert any effects. And finally, my conclusions would be that many of you have heard. what is clearly may not be, or the important issue obviously is what happens in the patient, and in particular the early studies where the effect of VTEs was not carefully considered or was not taken into consideration when planning the study. And one thing with respect to the Henke study was the initial publication that the initial aim was different. It was somehow attacking the hypoxic microenvironment. And the idea was, and this was based on animal experiments by Peter Volpel's group in Mainz, the issue was to address the hypoxic microenvironment by increasing the hemoglobin concentration, potentially to go beyond what we now know is good. So this was obviously, as we know from the clinical data, not the right way, although the animal experiments indicated that it might have been successful. What we have to carefully consider with VTEs is a different coagulation system we have in rodents, and this is certainly something that in basic science has to be considered. Still, with respect to the EPO receptor, the antibody that is now generated by Amgen may be helpful. It is not yet working in immunohistochemistry, but it is working in other Western blots and fax sorting. So the issue of having a valuable antibody to then look into patient samples is one of the tasks for the future. Thank you very much.